Ganz herzlich willkommen zu diesem kurzen Webinar.
Welcome to this webinar in which I will tell you the most important points of an implantation. In the first step, we take a look at the incision technique. In such a situation where we have a very broad, nicely attached gingiva, we can insert flaplessly. We use the rose burr and all other burrs and penetrate the mucosa directly. We do not punch, because the wound heals better if we drill directly, instead of having the sharp wound edges of punching. You have to consider here that we have a really broad attached gingiva. So even after the implantation, here you see the internal lift, we still have 2 to 3 millimeters outside of the implant circumference. With a countersink, what you see is what you get. You see that in this case we can achieve this state. When we turn it in, we see that we definitely have several millimeters of attached gingiva outside of the implant edge left, especially vestibularly, as you can see in this case. But for most of the cases, we do as follows. We create a flap, particularly in cases like this one here, where the attached or keratinized gingiva is only visible on the alveolar ridge. We cut exactly along the lingual circumference of the later implant, and then we shift the keratinized gingiva from the center of the alveolar ridge vestibularly. The advantage is that the diameter of the implant, that means 5 millimeters in this case, is gained in volume, because the volume of the attached gingiva is shifted vestibularly. And when you take a look at the result later, you see that the effort is worth it, because here we see a perfectly keratinized gingiva around the implant. It's important here that we avoid a stress or tension on the wound by applying apical mattress sutures. Extremely important is the cleaning. Here you see the removal of cysts or foreign matter as well, maybe bone graft, maybe also amalgam fillings, root canal filling residues, and also the ligament needs to be removed completely to give the information to the brain that the tooth has been removed. Otherwise, it would take some days until the ligament is resorbed, and the ligament is the final nerve fiber that is in direct contact to the brain. The SDS drilling protocol is based on bone classes. Here you see the diameters 3.8, 4.6 and 5.4. And the protocol moves from bone class 4 to 3 to 2 to 1. So you do not have to decide if you turn left or right at the junction, but you always go 4, 3, 2, 1. You start with the rose burr, then you take the pilot burr, and then you have a small short countersinks 5-0 and 6-0 to give you a nice overview how much space you have to the neighboring teeth. And in bone class 4, we will see that we will only work with a small countersink and just open up the thin compact bone a bit so that it is not blast away later on. Here we see the process for bone class 2 as an example. In this case, we have already used the big counter that prepares the shape of the upper section of the implant. Possibly we underestimated the bone and cannot place the implant completely. This is what you see simulated here. So we remove the implant and we use the so-called compact bone drill for bone class 1, and then we can insert the implant completely, as you can see here. What kind of diameters do we use? We see that when we take a look at the drills, so we use the drills for the alveole, we take a look where it touches the alveole. Since this is bone class 2, in this case 3.7 bone class 2, we know the 4.6 implant will be the right one to place. In such a situation where the tooth 2.6 is implanted, it might be possible to work completely without drilling. So we just take the countersink and the drill, we put it into the alveole, we see everything fits well. This is the palatinal alveole, and just with an internal lift, the implant is inserted with the apical aggressive thread. In this case, we take a balcony implant with a torque of 35 Newton centimeters without needing to drill. The countersink use is very important. This is an example of bone class 4, 11 millimeter drill up to the second marking. Now we use the small countersink that just opens up the thin compact bone in the upper section to avoid condensing the bone during implantation or avoiding blasting away the bone when you insert the implant. In this case, we have bone class 2. We opened up with bone class 2 drill. Now we take the countersink and we place the implant, and now the shape is congruent in the upper section. That means up here there's no compression. We have a medium compression, maybe 35 or 45 Newton centimeters maximally. But in the crown, in the compact bone area, the torque must not be higher than 10 to 15 Newton centimeters. The ideal torque in the compact bone is 0 or even negative, because the compact bone is poorly vascularized normally. So if you compress the bone, you damage the vascularization even more, and with this you damage the tissue. This is true for all tissues. And of course, we know that from the decubitus with elderly patients. So our implant in the upper section offers ideal stability, is friendly to the tissue and to the soft tissue around. And together with the countersink, there is no compression in the compact bone area, and the lower section of the implant is completely designed for stability, together with the extremely aggressive and deep SDS thread with a low pitch. Now let's take a look at the countersink, why it is so important. Without using the countersink, this implant here would be shifted towards the front from this position because the hard palatinal compact bone would push the implant forward buccally. So in this case, we would use the countersink and scrape several times, even if vestibularly the lamella is quite thin. And when we insert the implant now in this situation, we have the right position, we have the right axis, and we have enough space here left for the vascularization and regeneration of the buccal papilla. Very important is to retain the compact bone. So in bone class 1, the compact bone drill is used. So in the upper section we don't have any compression. In cases where we do not have any vascularization as simulated here, it even makes sense to use the next bigger countersink, and whatever is gray here will be a cavity. That means torque is negative. This is okay in the upper section because in the lower section we have an extremely strong and high stability due to the aggressive thread. In bone class 1, only the thread tips engage with bone class 1. The thread depth is 0.15 millimeters. This is the ideal depth. And whatever you see in pink here is a cavity. So based on the Beiken principle, these are stem cell lacunas or bioactive containers according to Ernie Fuchs. With our drilling protocol, we avoid the compression of the purely vascularized compact bone due to the very deep thread and the oversized preparation. We have an ideal stability of 35 to 45 Newton centimeters, but only at the thread tips, so we do not overheat or damage the bone. And we have stem cell lacuna, and with a speed of 10 to 15 micron per day, new lamellar bone with Haversian canals and blood vessels can form there. Let's take a look at the use of the PRF membrane together with the implants. There are 2 to 3 things that you should consider. In such a situation, where you have a huge NICO above the implant opening, so we clean the NICO with a piezo in this case. If you, or actually in this case, we would like to fill the hole, not only with an implant, but also with a PRF membrane. But in this case, we are limited due to the hard compact bone of the sinus, and dorsally we don't have any other opening of another NICO surgery. Extreme pressure could build up that could not escape, because the PRF membrane extends a bit because it takes up blood, and then it creates pressure. But in such a situation, where you have the implant opening and then the NICO window next to it, in such a case, when we put a membrane in, the pressure can escape through the NICO window in this case. So even underneath the implant, we can use PRF membranes. Well, this is the end of this short tutorial. And I would like to thank you for watching this video.
Das Anschauen.